in listen-only mode. If you have questions during the presentation, please submit them via the Q&A portion of the WebEx on the right-hand side of your screen, and we will address them as time allows. The slides from this webinar, as well as a recording of the event, will be made available on the provider page of our website by tomorrow afternoon. Additionally, we thank you for your participation in a brief poll that will be issued during the last 5 minutes of today's webinar. Our presentations today include updates on COVID-19 vaccine distribution in New York City and updates on the epidemiology of COVID-19 in New York City. And with that, I will hand it over to Dr. Mary Foote, Health Systems Planning and Strategies Lead for the agency's outbreak response.
Great. Thanks so much, Allie. And hello, everybody. Good afternoon. Thank you so much for joining us today. Next slide. And we're going to start out with just reviewing new developments and guidance as per usual. And then we have Dr. Corinne Thompson going over recent epi of COVID in New York City. And then we have the pleasure of having Dr. Jane Zucker here to give updates and answer questions on COVID-19 vaccines and distribution. Next slide. All right, so where are we now? Worldwide, we are now over 87 million cases and over 1.8 million deaths. As of course, disease activity unfortunately is surging in multiple nations and much of the U.S. forcing new and repeat economic shutdowns. In the U.S., we are up to 374,000 deaths, and CDC estimates that by the end of the month will be over 400,000 deaths. Our daily death rate, unfortunately, is well over 3,000 right now per day. We're reaching record high, both deaths, daily death rate, and record high hospitalizations. And just to put this into perspective, I heard this today, and it really struck me, especially as a New Yorker, that, you know, we're talking about way more deaths per day in the nation from COVID than we saw in the entire 9/11 event. So I just, you know, every day we're having more than one 9/11 in terms of death and body count. So I just think that's really sobering thing to remember. And then on the bright side, fortunately, a little bit of optimism. We are now rolling out the COVID-19 vaccines, and that has really begun in earnest in several areas, not just the US and Europe, but also China and parts of the Eastern Mediterranean. So, you know, we really hope there's good light coming at the end of the tunnel. SARS-CoV-2 variants that may be more easily transmitted than other variants have been identified recently, and we'll talk a little bit more about that on the next slide. And cases have increased steadily in New York City since September, although our healthcare system, fortunately, it has been a slower incline, and so it has not strained the system to the degree that it has in spring, but we are definitely starting to, you know, feel the impact. Next slide. And really wanted to cover just a little bit of extra information about these emerging SARS-CoV-2 variants. So, like many and all RNA viruses, SARS-CoV-2, it's expected to mutate, and it mutates regularly, about one genetic mutation every 2 weeks. What's really been in the news, and I think there's been a lot of interest in, of course, is the new recently identified variants in the UK and South Africa that do seem to be more easily transmitted than other variants. One particularly is the B117 that has been first detected in the UK and really took off very quickly there to become the dominant strain, and is thought to be really the driver of the big uptake in hospitalizations there. And then in South Africa, it's the B1351 strain, which has spread to surrounding African countries and has been identified in Europe, but is not quite as widespread to date as the B117. Though, you know, it really seems to be driving hospitalizations. That's really more of a numbers game. Just more people being infected leads to more hospitalizations, but it's important to note, as of now, the current scientific consensus is that these strains do not appear to be more severe and do not increase risk of death. And immunity, right now at least, it is thought that immunity from prior infection with another strain or vaccination immunity is expected to be effective at preventing infection with these new strains. But this, of course, is being looked at very, very closely. and this should not impact current ability of diagnostic tests to be able to detect these variants, and that applies to both the antigen testing and the molecular testing. And one thing that we are, there is some concern about, but it hasn't been shown to be an issue yet, but again, it's something very that's being watched very closely, is that some of the new monoclonal antibody treatments that have been approved may potentially be less effective against these variants. So because some of the mutation is primarily on the spike protein, which is where these monoclonal antibodies target. And then as far as New York, what we're doing to look at it, we are regularly sampling New York City isolates with genetic sequencing to monitor for emerging strains, and that's something that's been going on throughout. However, we obviously want to have the capacity to do more of this testing. New York City is collaborating with New York State academic and CDC partners to expand our sequencing capacity. And it's of note, as of yet, we have not found this strain in New York City, but there has been a case identified in Saratoga Springs in a patient that has no travel history. So it is in New York State, but has not yet been identified in New York City. But again, really going back to the core elements, what works against old strains are expected to work against new strains: physical distancing, the use of face coverings, rigorous use of PPE, really remain essential to preventing the spread of all variants. And that's a huge message to pass to your patients. Next slide. And finally, I just wanted to cover the new kind of hot off the presses guidance, that clarifying guidance that came out from the state yesterday on quarantine for healthcare workers that have been exposed to COVID-19. So at the end of December, there was guidance released that the state was allowing reduced duration of quarantine from 14 days to 10 days. There was still some questions remaining about how that would impact healthcare workers. So we got a little further clarity, which we appreciate. So for healthcare workers in hospital direct care settings, they are no longer permitted to work during quarantine. There has been somewhat of an exemption for facilities with severe staffing shortages. There is clarity now that there can still be permissions to allow exposed healthcare workers to work when there has been severe staffing shortages. However, there's a new process that is a little more formalized in order to make requests and get approval for these exemptions. So per the state guidance yesterday, strategies must be in place to mitigate staffing shortages, and they refer to the CDC's guidance, as you'll see in the references below, as guidance for that. And then after that, the facility has to, there's a link to a web form where the facility has to document that they have taken the steps to mitigate staffing shortages, and also have a signed CEO attestation documenting the severe staffing shortages that threaten the provision of essential patient care. And then after that is submitted, then it must be approved by the New York State Commissioner of Health before exposed healthcare staff are permitted to work due to staffing shortages. So we just wanted to make sure everybody was aware of those new processes. Another really important thing to note, there is still a bit of a carve out for healthcare workers at nursing homes and adult care facilities. This does not apply to them. They are still not allowed to work until 14 days after an exposure. So as we have seen throughout, there has been a lot more caution with the safety of healthcare workers and residents in nursing homes. So next slide. And I just wanted to highlight a couple of new resources that we have on our website. One is a really nice overview of all the different testing modalities that are available now. It's very nice and clear. I encourage you to take a look at it. And we also have a new framework for providing outpatient medical care and maintaining essential services during a COVID-19 surge. Just yesterday, we also posted a new resource for those of you that are vaccinating staff already. We also have a new guidance for assessing healthcare workers with symptoms post-vaccine, so how to manage those symptoms and how to address whether it's vaccine-related or potentially needs to be further worked up. So look for that on our provider website for vaccines. Next slide. And now I will turn it over to Dr. Thompson to give updates on the epi situation in New York. Thanks.
Good afternoon, everyone. Thank you, Mary. I'm just going to share my screen here shortly. Okay. Hopefully you can all see that. So I know that everyone's very interested in vaccines, so I'll just keep this very short. My name is Corinne Thompson. I'm one of the co-leads of the Epi Data Unit here, and we're responsible for a lot of the reporting out of the COVID surveillance data. I've been on here before, but just in case for those of you who have not, this is our webpage. And just to note before I go into the bits of interest this week that you can download all of our data here through this link. We have all of our data updated at 1 p.m. every day, saved in these folders, and we also have pretty extensive documentation for those of you who are interested in it. So not surprising, but still worth mentioning, we are increasing in all of our metrics here. Average case count total now is about 4,500 cases per day by date of diagnosis. We're having about 260 new admits to hospitals by day, and then the total death count, we're seeing about 50 confirmed and probable deaths per day. All of these are increasing. Just a couple things to say on this page. So this is a map of the 7-day percent positivity. The darker the red, the higher the most recent percent positivity. We have seen a stabilization of trends or patterns anyway. Staten Island is very high. South Brooklyn's very high. East New York and Jamaica here, South Ozone Park has been consistently high for many weeks now. And now we're also seeing parts of the Bronx, especially the Central Bronx, that are quite high. I'd encourage you to explore both the map, which you can hover over and see information. You can also get a tabular format here. You can sort. You'll see here Sunset Park. It's a bit small, the text here. Sorry about that. But Sunset Park is now a 7-day percent positivity of 16%. Which is definitely something we have not seen since the first wave. Also one of the things I wanted to point out, this is percent positivity by borough over time. The borough is shown in green here. This is the Bronx. The citywide is shown in blue, citywide average over time, and then each zip code in the borough is shown in the gray. And one thing that we've noticed very striking recently has been a dramatic increase in the percent positivity in the Bronx. You can see the majority of zip codes in the Bronx are higher than the citywide average. Brooklyn is about half and half. You have half this is mostly South Brooklyn up here above the citywide average. Manhattan, you'll notice the majority of zip codes are below, which is consistent. We find that testing is very high in Manhattan. Percent positivity is very low. But just want to point your attention to both Queens and Staten Island. Queens, you'll start to see the zip codes are starting to increase, but Staten Island specifically is definitely concerning. The percent positivity here is growing. We also, I just want to show you these are our epi curves here. Cases, hospitalizations, and deaths. Not worth necessarily going through at that time. Right now, I just want to show you the percent positivity by age here is something that we update. And as mentioned recently by our commissioner, the percent positivity among the 75s and olders has grown dramatically pretty recently, and their testing rate is quite low, or lower than the citywide average. So you can see here, I don't know if you can see the text is small, but we're about 12% for the 75s and olders. Also just to mention, again, our 13 and 17-year-olds still very high. They're at about 13%, and 5 to 12s are also at about 13%. And then just before I go, we have more information here, obviously, but I can skip that hopefully for now. Sorry, one more thing on this page. Sorry, I'm going quickly. I don't want to take up too much of your time. So we're seeing a stabilization in testing trends, actually. This is a bit affected by the recent holidays, which are the drops here. The light blue is the number of people tested by PCR on a daily basis, and the gray here is the number of people tested by antigen. The solid lines are the 7-day average. So we're seeing about 56,000 people tested by day by PCR and about 13,000 tested by day by antigen tests. So it's interesting. Stabilization. And then one more thing before I go, just to show you here on the trends page, just to note that in our epi curve from the beginning, which is loading, we are now, our case counts by diagnosis date are now about equivalent to what they were at the peak in April here. This is very different situations. To get a test now is much easier. There's a dramatic undercount in cases here in the beginning of the first wave, but just wanted to highlight that, we're now certainly seeing a dramatic acceleration of cases. So I think I'll leave it there, but I'm very happy to answer questions. Thanks.
Hi. Can you guys hear me?
Hi, Dr. Zucker. Yes, we can hear you. Thank you.
Okay. I didn't know whether I should just launch in. Okay. So I'm sure everyone wants to know, have updates on the COVID-19 vaccines and how vaccine distribution is going in New York City. So next slide, please. So I'll give an overview of the distribution and an update on some of the clinical considerations, what you need to do to prepare to provide COVID-19 vaccines if you haven't done this already. And then I'm sure there'll be lots of questions, so I hope to leave enough time for that. Next. Okay, so the first COVID-19 vaccines were authorized and recommended for emergency use. The first EUA was for the Pfizer-BioNTech vaccine on December 11th, and then Moderna followed a week later on December 18th. The overall vaccine efficacy was high for both vaccines at 95 and 94%. And what was really quite good to see in the data was that the same high efficacy was maintained across the different age groups in the trial and different race and ethnic groups as well, and across most of the groups with underlying medical conditions. And so that had been a concern since we know flu vaccine, the standard dose flu vaccine doesn't work as well in people 65 and older, and there was concern for this vaccine as well. But the data again shows the same high efficacy in the 65 plus. There were no significant safety concerns identified in the trials, although as has been discussed before, there certainly is local and systemic reactogenicity after the vaccine in terms of talking about local reactions and systemic reactions. And these are particularly, they're more common after the second dose of both vaccines. Next. So we're in that early period of vaccine distribution. We're only in week 4 for perspective, and we are in the phase where demand is exceeding the available supply of vaccine. And the Advisory Committee on Immunization Practices has provided recommendations on how to prioritize use of this limited supply for the initial phases. And what it really focuses on is prioritizing people who are at high risk for either exposure to COVID-19 or severe illness if they were infected. And then how it works is, right, there's this guidance, and then the states take the guidance and operationalize it into specific recommendations and decisions about how to distribute the vaccine in their jurisdiction. Next. So this is the phase 1A where we are now, and right, we started in the first week or two, we were vaccinating high-risk hospital workers. So this is all, right, healthcare personnel in these settings, including whether it's the doctors, nurses, but also people involved in all sectors of running the hospital and running the units. So this was emergency room and ICU staff, pulmonary department, federally qualified health center staff as well, and urgent care providers. Residents and staff at nursing homes are being vaccinated. That was in the first week, and they're being vaccinated through a CDC long-term care facility pharmacy program. EMS workers were added, as were coroners, medical examiners, and funeral workers who have direct exposure to body fluids. And then the state also added staff and residents who are at the persons with developmental disabilities, the mental hygiene hospitals, and the Oasis for substance abuse facilities as well. And then people who are administering the vaccine, including health department staff, can also be vaccinated. There was an update on January 4th, which had further expanded this to include all outpatient ambulatory care. And these are frontline high-risk healthcare workers of any age. And this is for direct patient care, as well as, and then just to notice the same idea that it's really all staff. So it includes your, for example, receptionists as well, the intake staff, included frontline high-risk public health workers who have direct patient contact, including those who are doing COVID-19 testing. And then this next bullet, which I won't read, but it's really a wide range of, all types of medical personnel who are providing direct inpatient services where there is direct patient care. So we're looking at, dentists, orthodontists, for example, psychiatrists and psychologists, physical therapists, pharmacists, pharmacy aides, home care workers, hospice. So again, these are, a common theme through this is just the direct patient care portion of their risk. Next. So we do believe we'll be moving soon into phase 1B and just anticipating where vaccine allocations will go. The sort of 1B group is really two distinct groups. One, it will include people over 75 years of age and older, and I think from the epi data that was just shown, it's obvious why this group needs to be prioritized. And then there are also frontline essential workers again, who through nature of their work can't socially distance on our front line. And this is expected to include a range of teachers and education workers, first responders who are not medical, public safety workers, as well as public transport. After 1B, the group that was identified by ACIP are people 65 to 74 with underlying medical conditions, additional essential workers, and then we would be expanding. The 1B should also include we'll move on to younger people with underlying conditions sort of under 65, and then really not until the summer will we get to the general population. Next. So I think that there are many options now for people to get vaccinated if you're in a currently eligible group, depending upon the setting where you work. So if you're affiliated with a hospital network, an urgent care center, federally qualified health center, or one of the congregate settings where vaccine is being offered, we would anticipate that you would be vaccinated by your employer. But we know there are many, many other eligible groups where their employers don't have vaccine, and so that's why there's been vaccination clinics have been set up across the city, and more of them are opening. So what we want you to do is really visit this the nyc.gov/vaccine locations, so you can find information about where to go. And I know that they are taking appointments for this weekend and into next week. So if you want to get vaccinated and you haven't been able to do that through the employer, please go to this website. Next. So the role of the health department is to allocate vaccines to providers that are serving these priority groups. So that's why we started with providing vaccine to hospitals, moved on to federally qualified health centers and urgent cares. We are assisting sites with facility registration for the citywide immunization registry, which is the first step, and afterwards completion of the provider agreement, and then vaccine ordering, and then we distribute vaccine. We are working to ensure there's equitable allocation and availability of vaccine for all New York City residents. We've been issuing guidance and recommendations to providers, as well as public information. There's a lot of information about just proper vaccine administration, the storage and handling, and best practices to ensure high uptake. The mRNA vaccines are not your flu vaccine, and just really require stricter storage and handling, as well as handling of the vaccine itself to not disrupt the lipid sort of nanoparticle layers and disrupt the vaccine. And then the health department is also administering vaccine at these vaccination clinics, points of distribution, but what we're calling our vaccine hubs. Next. So this was updated data. This is last night's data. So these reserved doses are just doses that we know have been allocated to us that the ordering had just opened up. Overall, we've delivered almost 490,000 doses to the city, and over almost 158,000 people have received vaccine, and 10,000 people have received dose 2. I will say that vaccine has really picked up this week, which is really great to see. I think the slower start during the holidays, I mean, I think there were several reasons for initial lower vaccination, but I think as people are gaining more experience with the vaccine, I think clinics themselves are going faster, and I think that more people, there's some increase in confidence as the initial vaccinees were okay, no major side effects, and that some people are sort of more willing to be vaccinated. Next. So we do expect, as we have more supply, it will enable broader distribution. New York City is closely working with the state to follow those requirements. And then, vaccine will be available at these sites, but I'll just say that most of these sites have vaccine now, fairly qualified health centers. We're going to start distribution to large independent providers that have enough staff, because the minimum order for Moderna is 100 doses. So we're going to start getting vaccine out to these providers. We're going to start getting vaccine out to the pharmacies. Urgent cares are providing vaccine in the hospitals and H&H facilities. They're also going to be running vaccination clinics. And we'll be offering vaccine at least for the COVID-19 testing sites. And then we are using community vaccinators to help us stand up some of these clinics. And I had mentioned these vaccine hubs are operating, with the first one scheduled for Sunday. Next. So just to touch on the clinical considerations, this was an MMWR that was released this week by CDC. So anaphylactic reactions after both the Pfizer and Moderna vaccines have been reported. And this is from data from the Vaccine Adverse Event Reporting System, or VAERS. They've had 21 reports, which is 11.1 per million doses administered. So this is about 1 in 100,000, which is more common than we would expect to see, for example, after a flu vaccine, which is more in the range of 1 in a million. And the median onset time was 13 minutes, and there was a range, but the majority, so 3/4 of these onset of anaphylaxis was under 15 minutes. The median age was 40, and there were 19% of people who were hospitalized, 3 who were in an ICU, and 80% did have a documented history of an allergy or allergic reaction to a drug, food, or insect bites, and a third had past anaphylaxis after prior vaccination. And there's no geographic clustering, there's no association with a particular vaccine lot. It's really believed to, it's like more universal across the vaccines, not that it's related to like a bad lot or anything. Next. So, just to touch on the contraindications, so because of the concern about anaphylaxis, this is what the updated guidance is from CDC. So anyone who has had a severe allergic reaction, and we're talking anaphylaxis for a previous dose of an mRNA vaccine or its components, should not receive the vaccine. And the components in the vaccines include the polyethylene glycol, which is in Valprep, is where most people would see it. It's in a number of other medications. And the other component that's of concern is polysorbate, and that's because of potential cross-reactive hypersensitivity with the polyethylene glycol. Next. So precautions. So if anyone's had an immediate allergic reaction to another vaccine or injectable therapy, we consider this a precaution. So these people need to be counseled about the history that they may have, there's an unknown risk for whether they would have a severe reaction. They can consult with an allergist or immunologist for appropriate testing to see if it's safe to move forward with vaccination. Allergic reactions that are not related to vaccines or injectable therapies or other components of the vaccine are not a contraindication or precaution. Next. So for this group, it's important that, as with all vaccines, we do observe people immediately after vaccination. So people with a prior history of an immediate allergic reaction of any severity should be observed for 30 minutes after they're vaccinated, and this is 15 minutes for all other persons. Next. There is guidance from CDC about managing anaphylaxis after vaccination, and this goes through early recognition, medication, and supplies that should be on hand, steps to take, and considerations for older persons and pregnant people. And then also, it is important if there is a reaction, really any adverse reaction after the vaccine should be reported to VAERS, but it is important when you're setting up a clinic, vaccinating, that you have the appropriate medication at hand if there should be an allergic reaction. Next. So just a word about vaccinating people with underlying medical conditions. So there were, people with diabetes, with lung disease, with heart disease were included in the trial, and these are people at high risk for severe COVID, so they should be vaccinated. The trials did enroll people with HIV or other people who were receiving treatment for cancer. They didn't really, these were people who were stable and who were not really severely immunocompromised. These people are at risk for severe COVID-19. So you can vaccinate these people because of the risk, that they pose if they did get COVID. But I think for people with immunosuppression, there's recognition because we don't have a lot of the immunogenicity data that these people may not respond as well to the vaccine as if they were not immunocompromised. For autoimmune conditions, it's the same thing, but there is a recommendation to sort of vaccinate people. They just were not included in the trial, and that just needs to be recognized. The same thing for history of Guillain-Barré or Bell's palsy. These are not precautions or contraindications, but these are conditions that are being followed in terms of the vaccine adverse event reporting, and to see whether or not there are complications in these populations that get reported. Next. So for pregnancy and lactating people, this was actually a really important issue. So these are not precautions or contraindications. These individuals can be vaccinated. There were a number of pregnancies that did occur during the course of the trial, and just given the timeline of the trials, we don't have the data on the outcome. But from an ethical point of view, it was felt to be really important to give these individuals the option to be vaccinated and not exclude them with a contraindication. So they may be vaccinated if they're part, and the recommendation is they're otherwise part of a group who's recommended to receive vaccine, and they are at high risk of exposure, they should be vaccinated because we know pregnant people are at risk for severe illness. There's no data on the safety and effectiveness. There is laboratory data that suggests that there is no risk, but given the nature of the vaccine itself and how rapidly the mRNA vaccines are cleared, there is not expected that there would be a risk to either the pregnant person, the fetus, or the breastfed infant. So it's really looking at their risk of exposure and likelihood of infection that really should drive whether they're vaccinated. And I think that, in follow-up to what I said, the ACOG statement here, reinforces that vaccine should not be withheld from pregnant persons and should be offered to lactating persons. Next. So persons with a prior infection, so they can also be offered vaccination to reduce their likelihood of reinfection. Since reinfection is uncommon in the 90 days after initial infection, these people may delay vaccination until they're close to that 90-day period. Obviously, people who have acute infection should wait until the illness has improved and the isolation period has ended. We don't want exposures happening in the vaccination clinic. We don't recommend testing people who are asymptomatic. If they're asymptomatic, they should just be vaccinated. And also, same thing for people who are in quarantine. After an exposure, they should wait until the end of that quarantine period to avoid exposing anyone in the vaccination clinic before they're vaccinated. Next. So, similarly, for persons who receive monoclonal antibodies or convalescent plasma, the recommendation is to defer vaccination for 90 days so that the antibodies don't interfere with the immune response to the vaccine. Next. So in terms of protection and when people are immune, this is the data from the trials. You would need an immune response. So, right, the protection by the vaccine is not optimal until 1 to 2 weeks after the second dose. That's how the trials were conducted. That's how they looked at vaccine efficacy. We do know that no vaccine is 100% effective, and we really have limited data. There was just limited months of follow-up in the vaccine trials, so we really don't know how long immunity is going to last from the vaccine. And there's not a lot of information about whether someone is vaccinated that reduces their ability to transmit infection. We do expect to get more information as the trials continue. So it's really important that vaccinated persons continue to wear a face covering and socially distancing, 6 feet away whenever possible, avoid crowding, and observe the quarantine recommendations. Next. So I think just some considerations for after vaccination of residents of long-term care facilities. CDC does have guidance on managing post-vaccination signs and symptoms for the 3 days after vaccination, right? Because people may have low-grade fever, they may have headache, they may have fatigue, and this guidance is important because we really want to avoid unnecessary COVID-19 testing and implementation of transmission-based precautions for these residents if these are only post-vaccination signs and symptoms. We also want to be careful because we don't want residents who are infectious to expose others to the facilities. So we would recommend that this guidance be applied to patients in other healthcare settings as well. Next. So specifically for healthcare workers, this is sort of small print, but CDC has published, and this is on our website, which was adapted from CDC guidance, what to do with an employee if they do have signs or symptoms that are related to vaccine. And so if they're the typical symptoms that are related to the vaccine, you should exclude them from work and evaluate them for COVID-19 or other symptoms, again, to avoid unnecessary exposure. But there are signs and symptoms which are not seen after vaccine. For example, cough and shortness of breath, those are signs and symptoms that should trigger, COVID testing and appropriate follow-up of the healthcare workers. Next. So preparing to provide a vaccine. So this is just background. We have information about enrolling in the COVID-19 program, and there's a lot of guidance specifically. CDC has a lot of great training materials on their website about this, and the vaccine storage and handling toolkits are important, right? Pfizer stored at -70 and Moderna stored in the freezer. And then the other guidance here helps you with, it's not like a flu clinic again. You have to set up a clinic to maintain, 6 feet between people coming in, and gives good guidance to how to operationalize that for any clinic that you're planning. Next. So, enrollment is open. It's been open for a month now for private practices, independent pharmacies, and other facilities that want to immunize adults against COVID-19. Right, so first you have to make sure that you have a facility code. You can get into the Citywide Immunization Registry, and then there's this online vaccination program provider agreement, which has to be completed. It gives us information about the facility, confirms your vaccine storage and handling information, shipping address for vaccine, and the populations that you serve. Next. So what we want is only one enrollment form per facility. And so if you're a facility or a network, you know, the network should complete like the provider agreement, which is Section A. That's the sort of place where people promise that they're going to follow all the guidance that's issued, that they'll report vaccine adverse events, they'll report to the citywide immunization registry. And then each vaccination site needs its own Section B listed, so we know about the storage on that site and where the vaccine will be administered. These agreements are signed by the chief medical officer or equivalent, or the chief executive officer. And the Part B sections need to be signed by a designated COVID-19 vaccine coordinator or the pharmacy director. Next. So I know we are getting lots of questions about when will I get vaccine. You know, we don't expect, you know, the general provider community to get vaccine really into the spring. We're really sending vaccine to facilities, you know, that are vaccinating, you know, the 1A population now, and we'll continue to expand into 1B. So it's really, you know, once we have opened up ordering so people can place orders, but just if you've placed an order, it doesn't mean, you know, that you're going to get vaccine. It's again based on this sort of prioritization guidance. Vaccine will ship directly from the manufacturer or the distributor to the provider. You will get a shipping notification when that happens. And then just nursing homes and adult care facilities are enrolled in CDC's pharmacy partnership program, and that's going on. Almost all nursing homes, they'll be finishing up their first visit this week, and they'll be moving into doing second visits at nursing homes. There's a handful that are being vaccinated by the health department because they weren't registered. And then the pharmacies have also started vaccinating at the adult care facilities this week and will continue next week. Next. So it's really important that people are able to report to the citywide immunization registry. That's how we're capturing the vaccine data. We want everyone to become familiar with the CIR, how you report doses if you're not already doing that. State law now requires doses to be reported within 12 hours of administration. You don't need written consent to report these doses. It's now required. The emergency order and the commissioner order referenced here require the reporting and waive that adult consent requirement. For those of you reporting through EHRs, you could just remove the adult flag, like the age restriction if you're reporting pediatric vaccines. And we really ask for your help with making sure that the race and ethnicity data that's in your electronic health records is populated correctly, because these fields are reported to us as well, but we're getting a lot of missing data, and this is really important for us to have to ensure equitable availability and for the distribution of vaccine. And there are also features in the registry where you can send at the facility level reminders and to your patients who are due for their second dose, and if they miss that second dose. So these are tools to really help facilitate complete vaccination. Next. So, you know, you need to see whether or not you have appropriate refrigerators and freezers to store vaccine. On the agreement, you'll be asked about the capacity to monitor vaccine. The standard is really digital data loggers for 24-hour monitoring of temperatures. Make sure you have sufficient supplies, right, whether it's needles, syringes, and so forth. And then the plans to safely vaccinate both your staff and patients to avoid crowding. And then also, you know, have a triage system to make sure that patients who will be coming in don't have active symptoms of COVID in advance. Next. So I think in terms of planning to vaccinate your staff, people are concerned about, you know, whether a lot of people will call out sick because of symptoms from the vaccine. So you should consider, you know, depending upon the size of your staff, consider staggered vaccination, especially after the second dose, and vaccinating staff 1 to 2 days before their scheduled time off. So their time off overlaps with when they may have symptoms and they won't be calling out. And then I think what's really probably most important is, you know, it's to educate and really talk about the vaccine, to prepare your staff and build confidence in the vaccine itself. You know, it works instead of offering vaccine, it's really important to provide that education, provide materials, talk about people's concerns, answer questions about the vaccine, and have people who've been vaccinated, talk to other staff. There are materials that are on the CDC website that can help with that. But this sort of laying the groundwork and foundation is just really, really important to help increase uptake. Next. So just in terms of, again, start preparing to offer vaccine for your patients. We expect, again, the next group to come up will be 75 years of age and older. Many of you will be able to identify this group using your EHR. To start that education and communication with your patients, as with all vaccines, the most important predictor of someone will be vaccinated is whether their healthcare provider recommends that vaccine. So we're asking all of you to be that trusted resource for your patients. And so it's important, again, for you to educate yourselves about the vaccine, be vaccinated yourself, and then answer questions, and instill that confidence for, in your patients. Next. We've mentioned sort of adverse events through the talk. It's a requirement in the provider agreement, but to make sure that we have a good understanding of the safety of this vaccine, be able to detect any adverse event that hasn't been previously recognized, it's really critical that adverse events are reported to VAERS after vaccination. That is, again, your patients can report, but it is a provider requirement, and especially if there's vaccine administration errors, there's serious adverse events, which include requiring medical care, hospitalization, and certainly deaths. If there are cases of multi-system inflammatory syndrome in your patients, and then I mentioned hospitalization or death, but again, you should also report any clinically significant adverse event. The point of reporting to VAERS is not that you think the vaccine caused it. The causality will be determined later through the investigation. And here's VAERS. Everything is done online, but there's also a phone number for assistance. Next. So VSafe is an app. It's a smartphone-based app that the patients can sort of download. It's another way that CDC is trying to get vaccine safety data, and people will get health checks via text messages and email. And so CDC has actually been looking at that information and starting to analyze it. And again, this will give us valuable information about how many people who are vaccinated really can't go to work, interferes with their regular activities. So we really encourage both for you when you're vaccinated to enroll, and then also encourage your patient participation. And there is information about the link to, although the link is that we can send out the link for VSafe after the call. Next. So there are required vaccine administration fact sheets. These are required under the emergency use authorization. There are also patient fact sheets. They are available in multiple languages on the FDA website. And then I also would refer you to the guidance about what to expect during the vaccination visit and after getting vaccinated. Again, that's important. That's that counseling and anticipatory guidance for potential symptoms. Next. So again, this is, I think, what applies for all vaccines. When you're talking to your patients about vaccines, starting from a place of empathy and understanding, assuming patients will want to be vaccinated, but they may not know what their when their turn will be in the guidance. So you could explain what your plans are to identify them when they're eligible. Again, you need to give your strong recommendation for a vaccination, and really listen and try to respond to patient questions. When sort of providers don't have the time to answer those questions, that is when from multiple different studies, patients sort of get turned off and get frustrated. They turn to the internet. They may not get reliable information there. And maybe just to sort of clarify one thing, so it's really saying, it's like, do you want your vaccine today? You're eligible for your vaccine today, as opposed to coming from a would you, a more, you can get a vaccine, it's optional, but it's really having this conversation with why you as the provider think your patient needs to be vaccinated, why they're in the risk group, and that's why you're recommending the vaccine. If patients don't want to be vaccinated on that day, or when they're called, to schedule another appointment so that there's another chance to get them vaccinated. Next. So there's just a lot of resources available on vaccination that I would refer you to. And we'll have another webinar in 2 weeks. And I think, is that the last slide?
Hi, Dr. Zucker. Yes, this is the last slide. So it looks like we have about 10 minutes for questions.
Okay, thank you.
So I will just begin by reading out a few that we have received in the Q&A box. And for those who do have questions and haven't yet addressed them to us, please do your best, if you can, to enter them into that Q&A box on the lower right of your screen. If we could begin, Dr. Zucker, if you can please just review, I know you did go over this, but review if a person has contracted COVID after receiving the first dose of the vaccine, what the procedure is, and how long they might need to wait to get that second dose.
Right. So they can get the second dose. I mean, the issue is you don't want them coming in when they're still contagious, right? So if they do have COVID, they need to, stay home to the end of their isolation period before they can get the second dose. There's no restriction. We do talk about sort of waiting the 90 days. And, I don't actually think there's specific guidance. I think the issue is really that they should, and that happened during the clinical trial. And, people came in and they still got their second dose after they were then no longer contagious, and finished that isolation period. So it's actually the short answer, because there's not really, right. Yep.
And there's a question about how well would a person be protected after receiving only the first dose?
Right. So, both vaccine trials, Pfizer and Moderna, did publish on people like 2 weeks after the first dose, and for example, Moderna showed an 80% vaccine efficacy after that. So 2 weeks after the first dose, so there was a chance for an immune response, but before the second dose. But this is really looking for a short time period, and I don't want people to take the take-home message to be you only need one dose. We don't know that. We don't know anything about long-term immunity after the vaccine, whether or not, just immunologically, you may really need that second dose as a sort of in a prime boost series to have good cellular immune response and have longer-term immunity. So, what's really important is that people need to complete the 2-dose series.
Thank you. And with regard to you had mentioned potentially waiting 90 days if a person is positive to receive their second dose. Can a patient get a vaccine, their first dose of the vaccine, within 90 days of having been positive for COVID? Will that be something that will need to be documented?
Right. So I think the issue there is that it's in a time of limited supply. If someone is diagnosed with COVID, they're unlikely to be reinfected in the next 90 days. So that's where that 90-day that they can wait, up until that 90-day period, just because their risk for reinfection is low, in that period. But they don't have to wait the 90 days. Again, I think it's just an issue. We don't want contagious people, right, coming in and getting vaccinated and infecting the vaccination staff.
Right. And for those who have a previous history of COVID-19, is there any research about that population having a more moderate or severe reaction to receiving the vaccine?
So I haven't, there will be data that will likely come out of the trial. I haven't seen anything published, although I am hearing some anecdotal reports about that. But it's just, so we'll stay tuned.
Yeah. Stay tuned for so much. We have a few questions about various groups and when they will be able to receive vaccine, but quite a few about whether or not there are any provisions being made to get vaccines to homebound populations.
Right. So that is under active discussion. I'll just let everyone know. I mentioned that the vaccine is again different than flu vaccine. There are real restrictions on moving this vaccine around. So for both products, once it's delivered and it's stored in the freezer or in the refrigerator, but once the vaccine is moved again, you're not supposed to move it again. And there's also all this guidance on the website CDC, like you don't want to shake these vials. You can invert them, but you shouldn't be shaking the vials. You don't want the vaccine sort of bounced around. There's concern that there could be disruption of the lipid nanoparticles. You're not supposed to pre-draw these vaccines up either, right? Some people will, like with flu vaccine, if you have a multi-dose vial, may draw up your 10 doses before people come in to sort of speed up the clinic, but you're not supposed to be doing that with this vaccine. There is concern, again, about the vaccine interacting with the syringe and not wanting to sort of leave it in there, for any length of time. So this is just really a different vaccine, and I think that bringing vaccine into homes and into smaller settings is going to be very difficult. There are other vaccines that are in phase 3 trials that are more stable that might be more appropriate for those purposes.
Thank you. And we had quite a few questions also for those who are having trouble with the citywide immunizations registry, including those who represent private practices who have registered but are unable to enroll in the vaccine program. It doesn't seem like the function is available to them yet. If they need assistance, should they just go to the website that is linked on the page, or do you have further assistance you might be able to provide?
No, there's like 1,000 reasons why that might happen. And I don't know, like we've been adjudicating each, like working with all the providers, and we've been prioritizing providers that are serving the risk groups. I think that for a provider that has never reported to the registry, setting up that connection, whether it's through your EMR or understanding how to report to the registry, getting your facility code, there is, some time to set those up, and then you have to go into the provider agreement. So this isn't a one-day, turnaround, and it really depends on whether your, what your setup is in your office and the EMR. But there is, go to the CIR website. There is an email address, and again, we're working everything out with all the providers that are having challenges.
Thank you. And to those who are still with us, thank you also for noting that our poll has opened. We appreciate your responses there. It helps us to identify what types of topics to present in our upcoming webinars. Dr. Zucker, we did have a general kind of a core 4 question. Curious about whether or not it's still recommended for general population to wear masks after receiving both vaccinations.
Yes. Yes.
Great.
Right? The vaccine is not 100% effective, and what we don't know yet is whether or not maybe you're protected from infection yourself, or maybe you're protected. The trial was symptomatic infections. They haven't released data about asymptomatic infections, so we don't know whether vaccinated people can have asymptomatic infection and can still transmit COVID. So until we have more information about that, it's important to maintain the core 4 to prevent ongoing transmission.
Thank you. And then if Dr. Thompson is still with us, we had more of a data question, wondering if there are plans to publicly share equity data about vaccine distribution. So, vaccine distribution by zip code, age, that type of thing.
So we do plan that. Yeah. So it's Jane. There is some information on our website now about that. The people we vaccinated really reflect healthcare personnel at this point. But that's absolutely our intention. And there is actually a map showing where vaccination has happened. It's very much overlaid with where there are large hospital systems. But that data will absolutely be shared on the website.
Okay, thank you. And I guess we have time for one more question. You might not be able to answer this yet, but curious if there's any estimate about when phase 1B will begin.
Mike, I'll give you an educated guess. Soon.
Great, thank you. Okay.
I think it's very appropriate. I think it's just very appropriate for everyone to really think about their 75+ population, and what their approach will be to vaccinate those patients.
Okay, thank you. It looks like we're right at 2. So with that, I just want to remind everyone that, oh, sorry, there's some feedback, but that we will be posting the slides as well as a recording of the webinar on the provider page of our website, which is one of the links that you will see at the top of the screen right now. And also be emailing this information to you early next week. And our next webinar will be Friday, January 22nd from 1 to 2 p.m. We will be sending out information on how to register for that, and you can find that on our provider page as well. And we thank you again for joining us today.